Do you have anxiety? Well, if you're a human being, the answer is yes. Now, is that healthy anxiety that, although distressing, is serving you? Or is that clinical anxiety that is impairing functioning and is a disorder to be evaluated and treated? What are those treatments? To help us figure this all out, back for the second time, Dr. Pat Baumgart. So Pat did his medical school at Creighton, residency at UCLA, which is of course where we met, fellowship at USC, and is now an outpatient psychiatrist working in the community and also doing some excellent work over at USC Keck. Pat, nice to have you back on.
Thank you, Dr. Mah. It's a pleasure to see you again.
Okay, now for the audience, what are we covering today? We're going to talk about what is anxiety, what's healthy, what's clinical, what sort of treatments are available, therapy, different medications. We'll get into the nitty-gritty. We'll talk about SSRIs, benzodiazepines, beta blockers. We'll talk about different types of therapy. We'll talk about skills you can use in the moment when you are feeling this rise, maybe panic, how to calm yourself down in the moment. We'll talk about popular topics like loneliness, coronavirus, current events, which I think a lot of people can relate to, a lot of stuff happening right now that can bring up a lot of anxiety and fear. We'll take some audience questions, and that is a roadmap for today. Welcome, guys, to Real Mental Health. Okay, Pat, for the audience, let's start off and talk about what is an anxiety disorder? How do you define it? What is clinical anxiety?
Sure. An anxiety disorder is something that many people, I think, in the lay community and the professional community are very familiar with. We're all familiar with this sense of worry, the sense of dread, perhaps, the sense that perhaps what's in front of us or what we've been through will go wrong or has gone wrong in some way that causes this overwhelming sense of distress. And I think the question most fundamentally is this something that helps us cope with stress? Is this something that gives us a sense of order, a sense of structure to our lives, or is this something that causes significant distress and gets in the way of who we are? So when we think about anxiety disorders, there's a lot of different flavors of different anxiety disorders. Many people will have a sense that something is wrong, and many people will have a sense that they've had these symptoms perhaps as long as they can remember. So sometimes people will present to primary care physicians with reported symptoms. Sometimes patients will present to their psychiatrist. And sometimes people will go through their entire lives dealing with these symptoms and may never seek treatment.
A lot to unpack just right there. Now, educate the audience, because all over social media, all over everywhere, people are talking about feeling anxious. And a big misconception is that people are thinking that just because I'm feeling anxious, that there is something wrong with me, that I have an anxiety disorder. So you mentioned a couple words, but can you help us differentiate what is this healthy anxiety that attends you to whatever threat is present or in front of you? And what is a clinical anxiety disorder that should be evaluated and treated? How do you differentiate between the two?
Of course. So I think many people, especially people that are very responsible, very successful, very attuned to their academic needs, their work needs, their interpersonal relationships, and other responsibilities, have a sense that they need to be on guard at times. They need to be well prepared for things. For example, when I woke up this morning for this podcast, I wanted things to go well. Perhaps I worried a little bit that it would not go well, or perhaps there was some uncertainty about it. The question is, with any psychiatric disorder, it typically is characterized when it begins to impair your psychosocial functioning. Now, what I mean by that is it causes significant distress in your life. It causes problems with your interpersonal relationships. It causes problems in your academic performance. It may cause problems in your ability to work productively. It may cause problems in your sleep or with your physical health. And that's typically where we draw the line between what's healthy coping and perhaps what's a mental health disorder.
Yeah, that's super important. Now, I've said it again, and I'll say it again. Even a healthy anxiety, like you mentioned this morning, is distressful. It is uncomfortable. But just because it doesn't feel good and it's uncomfortable does not mean that it is a problem. Humans need anxiety to orient them to potential threat. Now, what Pat was saying is once functioning is impaired, social, professional, any sort of functioning, much like all psychiatric illnesses or disorders, then we talk about, is there a disorder here to be treated? For instance, can you give us like one example of a patient that you've seen lately and what their complaints were when they established care with you that led you to think, hey, perhaps there's an anxiety disorder here?
Sure. I, for example, have a young woman, about 35 years old, who has come to a psychiatric outpatient clinic for the first time. She was referred to her by her primary care physician. She is somebody who says she cannot sleep, maybe for as long as she can remember, maybe 6 months, 1 year, 2 years. Throughout the day, she feels a significant degree of muscle tension. Throughout the day, she constantly worries about many aspects of her life, her finances, her relationships, perhaps where she'll be with her career in the future. She additionally has some physical symptoms. For example, she feels nauseated, and at times when giving talks for her company, talks in front of people, she'll get sick to her stomach, she'll throw up, she'll have diarrhea, she has abdominal pain. So she's somebody who, as some people with anxiety disorders do, they don't have a clear sense of what's going on.
Yeah.
So she had presented to her primary care physician, and they had referred her to a psychiatrist with suggestion that this may be due to an anxiety disorder, and it was something that was maybe new to her or something that she didn't really understand what was going on.
Yeah, and that primary care doctor is excellent because a lot of the time it's not so easy to pinpoint that these symptoms, these gastrointestinal symptoms, this muscle tension, this insomnia is secondary to anxiety. In fact, patients may not land at a psychiatrist immediately. They might go to a sleep specialist, they might go to a gastrointestinal doctor, they might go to a functional medicine doctor. They might be attending to the downstream symptoms of anxiety for a while without clear and retained benefit before they even make their way over to a psychiatrist who will investigate, is there an upstream anxiety disorder that may be causing these downstream symptoms? And it's not so easy to tell because anxiety can manifest in so many different ways. Sleep, GI stuff, having hives, for instance, any sort of physical symptom, and I'm not using that as hyperbole, can be a manifestation of anxiety. Now, let's see, where should we go with this? So let's dig into some popular anxiety disorders. There's generalized anxiety, there's social anxiety, there's obsessive-compulsive disorder. How do you conceptualize what generalized anxiety disorder is? What is that?
So generalized anxiety disorder is essentially a person who may have worry, concern, dread about everything in their life or many things in their life. They may have worry and concern as long as they can remember. Typically, people will identify various things that make them feel uncomfortable on a constant basis. And again, common things are common, but finances, relationships, housing, work, occupation, vocation, physical health, the well-being of others, current events in the world, for example, are all things that are common threads and come to mind for individuals with generalized anxiety disorder. So diagnostically, generalized anxiety disorder is identified as excessive worry that causes impairment of psychosocial functioning and typically persists for 6 months or more, as many anxiety disorders are characterized by the DSM. Not all, but oftentimes 6 months is the duration.
Yeah.
I think what's important to note about anxiety disorders is they are often chronic in nature. People will often have a sense of, I have always felt this way, but sometimes new onset symptoms may emerge. Sometimes people will have symptoms worsen during times of distress in their lives. But for somebody with generalized anxiety disorder, I would look for a pattern of excessive worry about many things causing impairment of psychosocial functioning. People may have insomnia, they may have irritability, they may have muscle tension, and they may have a wide range of physical manifestations that we previously described.
Yeah. If I put it in just a couple sentences, my GAD, generalized anxiety disorder, definition is, hey, I'm worrying about most things most of the time. And not only that, I have some other complaint associated with it. I'm feeling brain fog, I'm feeling fatigue, all that gastrointestinal stuff we just talked about. I'm having insomnia. And like Pat was saying, when someone has generalized anxiety disorder, they spend a significant amount of time worrying. Now, a lot of people may not even realize, because people spend so much time in their day engaged in tasks, distracted, and they'll tell me, hey, doc, I'm actually not really worrying throughout the day. It's just when I kind of turn down for the evening, get into bed, and I'm not so distracted or engaged in a task where this flood of worries is bombarding me. I have a delayed onset of sleep. It takes me a while. I try to do some sort of meditation, and still, it takes me like 45 minutes, an hour, hour and a half to get to sleep. And even when I'm sleeping, sometimes it's restless. That's a great characterization of generalized anxiety disorder. Now, are people born with this? How does it develop? Is there like a genetic predisposition? How is it that some people develop this generalized anxiety disorder? Where does it come from?
So like many psychiatric diagnoses, psychiatric illnesses, if we can call them that, it typically is a mix or a combination of various different aspects. So we think of anxiety disorders as being a common, perhaps, of a biological predisposition. So there is a genetic predisposition. Certainly, if you have family members that have anxiety disorders, you are at risk of developing or having an anxiety disorder. Certainly one's own temperament and your early life experiences and perhaps stressors that are in front of you contribute. Certainly things like substance use or medical illnesses, perhaps even the physiology of certain medical illnesses can predispose somebody to symptoms of anxiety. So it really is a combined picture and a complex picture, and it's hard to distill with a single etiology or a single cause. Yeah,
and there is no single etiology. So many different stories lead to generalized anxiety disorder. Genetic, how you're raised, everything you just mentioned. A common question I get is, doc, I know I have this anxiety disorder, but it's part of my edge. My worry about my finances makes sure I'm on top of everything. My worry about my work makes sure that I'm tuned in, going above and beyond, and double checking all of my work. What if this generalized anxiety disorder, although it's costing me my health and my sleep, and perhaps the irritability that is leading to trouble and like conflict in my relationships, what if I treat this and then I lose the edge associated with this generalized anxiety disorder? I'm a high functioning, anxious person. What do you say to these people?
I would say that's a very valid question. That's a very valid thing to identify. That's a very valid concern you may have. And many people that are highly functioning have a tremendous sense of neurosis. And by that, I mean a sense of worry or anxious distress. And you're right. In some circumstances, it can be very protective biologically in the face of a threat, whether it be a threat for your physical safety, a threat for your financial security, a threat for your interpersonal relationships, a threat for your future, that is productive in some sense. But I guess with many patients who ask this question, I would consider, to what degree is this helping and to what degree is this impairing your life? Mm-hmm. And I think that can be a difficult thing to differentiate in some circumstances. In some patients, it's clear that their symptoms are much more distressing than they are productive. And in some patients, it's more equivocal. But I think that's a careful consideration, is to take a step back and ask the patient, how is this negatively impacting your life? To what degree is this causing problems? And then take it back from there.
Exactly. I mean, they've shown up to my office. They're here with a complaint. Clearly what's happening, although serving you in X, Y, and Z way, is producing some sort of negative effect on your ability to live your life and be happy and content and healthy, that you've shown up to me. Also, considering the longevity of your life and your career, is this a sustainable model in which you are driven by fear and anxiety in order to function maximally? I would make the argument, and I would die on this hill, that although great things can be accomplished through this sort of neurotic worry and anxiety and compulsive behavior, it's not the highest level of functioning somebody can achieve. better to be driven by motivation, goal orientation, being in a calm and alert mindset, rather than compulsively driven by fear in order to accomplish. It ruins your body. I mean, like you said, these things are chronic. You don't even diagnose someone until they've had symptoms for more than 6 months. But these things are rough on your body, not just physically and the insomnia and all the rest of it, but it's not very sustainable. You can only be driven by fear and anxiety for so long before you lead to trouble with burnout, before like all of these health problems catch up with you. So yes, can you get away with this and be successful? Of course, but is it the highest level of functioning and give you the best mental health? It's not. And that's why you're here seeing me, right? Now, before we dive into treatments for generalized anxiety disorder, we're going to talk about some other anxiety disorders, because what we find is there are a lot of commonalities in the ways that we treat anxiety disorders. So we'll get to those after we cover a couple other ones. Now, any other bits on GAD before we move on to talk about obsessive-compulsive disorder?
Sure. I think the final thing I might mention, there's a lot of patients that come with a primary complaint perhaps of difficulty with concentration or attention. A lot of patients will be familiar with at least the concept of ADHD. And what I will say is, I will die on this hill, anxiety disorders cause significant difficulty concentrating and focusing. As much as people feel that anxiety makes them alert, it certainly distracts them from the scenario in front of them. It distracts them from good goal-oriented work. And I would encourage anybody who has a significant degree of anxiety to understand that as a component of perhaps significant difficulty with cognition and concentration.
Excellent point. If you feel like you are having difficulty focusing and concentrating, and the first thing you think of is, I must have ADHD, it is so important for you, but really your providers, to first rule out, is there an anxiety disorder that is tugging at your attention so that you have more difficulty focusing on the task at hand? And that's what anxiety does. Your body is attuned to a threat. What happens when we're in this state of perceived threat? We are literally built for our focus to be narrowed in on the threat, not doing our homework or doing our work at hand. So battling the anxiety-driven direction of focus to the threat in order to attend to the task at hand, you're fighting against your body's system. Of course, if you're worried about like your finances or what your mortgage is going to be or blah, 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 while you're trying to sit down and, see patients, for instance, you're fighting against your body.
You're distracted from what's in front of you.
You're distracted from what's in front of you for good reason.
Right.
You're picking up on some other threat. My house is on fire. How am I going to sit here and do my work and talk to this patient, right?
Correct.
It's me with the anxiety disorder. Now, quick question. Well, what is the difference between fear and anxiety? What's the difference and what's in common? Two different words, two different things. How do you explain the difference?
It's kind of like a Venn diagram, I would describe it. So we think about a Venn diagram as having two domains of different things that have some unique characteristics and some that overlap with each other, right? So fear, I think, is described as an appropriate appraisal, perhaps, or maybe not, of some sort of threat in front of you. And having fear is important in certain situations. I don't drive 30 over the speed limit because I'm afraid that I'll harm somebody, I'll harm myself, or I'll get in trouble with the law. I don't smoke cigarettes because I fear that I will have health problems and lung disease. There are situations in which fear is inappropriate. People have concerns that things are a threat in front of them that perhaps they are not. And maybe that's kind of where it more bleeds into the domain of an anxiety disorder. Where is the fear excessive? Where is the fear irrational? Where is the fear not based on what's in front of you? When is the fear not an appropriate appraisal of potential harm?
Yeah. I mean, you said so many important things there. The way I conceptualize it is fear is when there is a threat literally presently in front of you. Let's say there's like this bear, I'm in the woods. There's an acute fear response to a present threat right in front of you. Whereas anxiety is typically a worry about some sort of future outcome or threat. And what you said is also incredibly important. Back to the definition of anxiety, is clinical anxiety is typically an overestimation of the likelihood of a negative outcome and an overestimation of the severity of that negative outcome. Like, oh my God, for sure, this is going to end up in the worst possible case scenario. Catastrophizing is a popular word that we use and see all over the internet. So is the fear and worry disproportionate to the threat at hand?
And that's the hallmark. And somebody once told me that so many of the things that we worry about don't come true. Perhaps
Absolutely.
If it's future-based. And I think it's important to kind of take a step back and consider that this is excessive. This is something that doesn't have a strong likelihood. This is something that is not realistic. This is something that is impacting my life and is distracting me from what's in front of me.
Yeah. Hey, everybody. Dr. Mike Mah here. I'm very excited to announce the launch of my new group practice, Century City Psychiatry. I've personally hand-selected a team of mental health providers that will be practicing evidence-based, compassionate psychiatric medicine under my direct supervision. If you or anybody else is seeking care in the state of California, visit www.centurycitypsychiatry, fill out the form. We will be starting with new patients in about 1 month. Thank you very much. Anxiety disorders are fear-based, right? The fear of the future, the fear of the present. These are fear-based disorders, which is actually one of my favorite reasons to treat anxiety disorders. It can feel actually just more cut and dry. I say that with hesitation. All the psychodynamic therapists out there are going to look at me and laugh. It seems a little bit more cut and dry than discussing like major depressive disorder, for instance. Because for me, when I conceptualize it, I go back to this fear model of overestimation of negative outcomes and overestimation of their severity, and whether or not this clinical fear and this clinical worry is driving behavior, external behavior, internal behavior. We're going to get back to that in a second as we talk about OCD and also when we talk about treating clinical anxiety disorders. But little preview, when you allow this clinical fear and this clinical anxiety to dictate your behavior, you're actually perpetuating the cycle. We're going to come back to that in a second because that's a foundation of OCD treatment. But let's talk about OCD, Obsessive-Compulsive Disorder. What is OCD?
So obsessive-compulsive disorder is something that I think many people may have preconceptions about. Many people will confuse obsessive-compulsive disorder for what's known as obsessive-compulsive personality disorder. And I'll start there because a lot of people that are very well organized, very detail-oriented, very perfectionistic in nature, may have traits of what's called obsessive-compulsive personality disorder, which is different. So obsessive-compulsive disorder is an anxiety disorder that's characterized by both obsessions and compulsions. So what do I mean by that? Obsessions are these recurring thoughts that people have that oftentimes are highly distressing. They may be variable, but certain themes are concerns of cleanliness and contamination, certainly things like order, symmetry, perfection, locks being locked, or perhaps certain superstition, things like numbers, things like, for example, cracks in the sidewalk causing harm if you step on them. It's a common, perhaps, child obsession. And essentially, these distressing thoughts encourage people to engage in compulsions. So compulsions are these behaviors that people will do to release the distress of these thoughts. For example, a patient who has significant obsessions about cleanliness may engage in the compulsion of repetitive hand washing to the point that maybe they have excoriations or they have some sort of rash or abrasion or injury to their hands that causes significant physical symptoms. Somebody who has obsessions perhaps about order, symmetry, or cleanliness may engage in compulsions that have a significant amount of time cleaning that distracts them from perhaps their work obligations. Somebody who has obsessions about locks being locked may turn around on the highway and be late to work because they've checked 5 times whether or not they locked the front door. So the important thing to highlight or differentiate between obsessive-compulsive disorder and obsessive-compulsive personality disorder is it causes a significant sense of distress rather than as kind of a long-term enduring trait of perfection and attention to detail. That does not cause distress.
Yeah, I'm so glad you brought that up because that's a very important distinction. Clinical OCD, obsessive-compulsive disorder, versus obsessive-compulsive personality traits or personality disorder. My definition of a clinical obsession is a recurrent, intrusive, distressful thought of a particular theme. Now, one difference here in the obsessions of OCD versus the obsessions in a personality trait is what we call whether the obsession or the thought is ego-syntonic or ego-dystonic. In OCD, these obsessive thoughts are intrusive and distressful, and you cannot shake it even if you try. The obsessive personality trait, it's not an intrusive, distressful thought to be particularly obsessed with perfectionism and orderliness in your work or whatever. Those obsessive personality trait patients, they are not complaining about these intrusive, distressful thoughts. The OCD patient is. The OCD patient's obsessions are ego-dystonic. It's causing distress. It's intrusive. Now, another very important point is in OCD, you have this obsessive thought. It's intrusive. It causes you distress. This distress often feels like anxiety or is anxiety. And this anxiety compels you to engage in some sort of behavior that provides you relief momentarily. Now, what is exceptionally important, part of my OCD education for my OCD patients, is recognizing that when you allow the obsession and that anxious state to drive behavior to these compulsive acts, these ritualistic behaviors, you are entertaining the fear, this clinical fear that's not proportionate to reality, and you are perpetuating your OCD. You are throwing fuel onto the fire. Well, doc, you don't understand. I can't help myself. Of course it's difficult. Fear is the biggest motivator of behavior.
Yes.
And I tell patients that. Of course, I'm not going to, just cut out the compulsive behaviors. I'll see you later. You're fixed. We have to understand that fear is one of the greatest, maybe the greatest motivators of behavior, and learning to sit with that distress and regulate it without engaging compulsively is one of the hallmark features of successfully treating OCD. In order to extinguish the obsession, we need to stop pouring fuel on it with compulsive behaviors. And again, compulsive behaviors do not necessarily need to be like motoric actions. They can also be psychological, internal counting, mental review. Oh my God, let me think. I'm socially obsessive. Let me think about every single interaction I've had with this person. Let me go over this iteration, that iteration. Mental review and mental kind of gymnastics can also be compulsive behaviors. Compulsive behaviors do not just have to be motoric and be like physically active. Do you agree with all of that?
I would agree with that. And I think one of the hallmarks, we're going to talk about treatment in a little while here, but one of the hallmarks of certain psychotherapies that can be helpful for anxiety disorders is attempting to break the emotional distress, the link between the emotional distress and the action, right? And that's something that perhaps a medication cannot do alone. Although medication will decrease the severity of the thoughts, doing good work and good therapy can give people skills to recognize their symptoms and break the cycle.
Yeah. We're going to talk about treatments for anxiety disorders and OCD specifically in a little bit, but it's important to know that it's a combo of both psychotherapy, ERP, for instance, we'll get into that, and medication management. Now, I am as judicious as everybody with psychotropic medications. I'm conservative, lowest dose, lowest amount of time, blah, blah, blah. But OCD, someone that is suffering from a clinical OCD, the medications are, God, I mean, please, if you are hesitant to start medication for treating OCD, I beg you to reconsider. I beg you to speak to your doctor, because one of my favorite reasons for treating OCD is these people come in sick and disordered and suffering. And my God, you can put these symptoms into remission with the appropriate medication at the appropriate dose for the appropriate period of time in the appropriate therapy. And people get this whole new lease on life. Now, one of the difficult parts of OCD is the patient has to accept the fact that life inherently carries a baseline level of risk.
Correct.
You cannot mitigate all the risk in life, no matter how compulsively you behave. Life is inherently risky. Catastrophes do happen. And that is just, we have to work with the patients to accept, because a lot of them have a very difficult time with that, which is why one of the reasons they have a hard time giving up their compulsions, because it's what's keeping them safe.
Correct.
Doc, I know that it's hurting me, but God, the worst can happen. I could be in jeopardy. there's risk.
But what are you missing?
Risk.
What are you bypassing as a result of risk? And I think that's really where you toe the line. Regardless of how safe you are, you cannot avoid all risk. And I think that many patients who have such a degree of fear, there is so much opportunity loss, whatever it might be, whether it be getting on a plane because you're fearful that it will go down, you don't see the world, whether it be not going to social situations because you may say something that's embarrassing, you don't meet your significant other, perhaps not engaging with an employer for an opportunity and having a significant financial or career opportunity loss, perhaps not wanting to attend a competitive university that may open up large doors for you in the future. You have to take some risk. You have to assume some risk, because with risk comes such potential reward, right?
Absolutely. I mean, that's such an amazing point, is you're sacrificing so much to mitigate X risk, contamination, for instance, what you mentioned. What about the risks associated with living in this untreated OCD state? Now, one of the exercises I do with patients is literally journaling out what are the costs of this defense, right? This compulsive behavior. What are the costs of it? You just outlined kind of what I do with these patients. Well, this has precluded me from going on this travel. This has precluded me from socializing this way. It's cost me this ability to thrive at work and social life and personally. Having the patient actually write down what the past, present, and future costs of this disorder are will help them in that, that front part of their brain have concrete evidence as to all of the risk associated with maintaining this defense of this sort of obsessive-compulsive disorder. Now, there's a lot of steps here, a lot of nuance. That's just one. But OCD, if you guys are suffering from OCD and you have any hesitation, please see somebody, see a psychiatrist. There's absolutely relief to be had. I mean, I have had severe OCD patients that can barely leave their house and function, that with the appropriate treatment for the appropriate amount of time, the symptoms have been put into remission. How have your success rates been with treating OCD?
Yeah, I think people can do very well. I think with treatment of any sort of psychiatric illness, similarly to any medical illness, certainly there's a range. There's people that make tremendous changes and some that don't do as well. But I think many people do benefit from the right treatment, and it's not necessarily a one-size-fits-all model, but educating people about their symptoms, educating people about potential treatment options, engaging them in the appropriate resources, many people will improve and will improve significantly.
Yeah, and on that point, it's not just the cost to you. If you want to take it one step further, what is the cost to your loved ones? What's the cost to your family, your wife, your husband, your children? Because OCD doesn't affect just you. It affects everybody around you that loves you, that relies on you, your dependents. I mean, it affects more than just you. Now, if we haven't given you enough motivation to go seek treatment for OCD, well, I hope we have. Now, anybody that has questions about OCD, leave them down in the comments. If you guys, we can do a whole standalone episode just on OCD. If you guys would like that, leave it in the comments. I see 13 to 17 patients a day. Been doing this for years. You the same, a little bit longer. One thing I've noticed, the seed of OCD, because like you said, it can be variable. When an OCD patient runs into some sort of problem that is out of their control, that can cause them significant distress, they can latch onto that. One thing I've seen a lot lately is sexual orientation OCD. I've heterosexual patients that get this seed in their mind that what if I am homosexual and gay, and what could that mean for my current relationship, my current marriage? When there is something that can disrupt your life that is out of your control, that can send OCD patients into a whirlwind of obsessive-compulsive behaviors and, thought process. They do, the compulsive behaviors in that case can revolve around gaining as much information and doing everything possible. But the crux of this seed is it's actually out of their control. Have you seen, what are some topics of OCD that you've seen commonly or more recently? And do you agree with that?
Yeah, I think many people fear with sexuality, especially those that come from backgrounds maybe that are very rigid or very specific or particular, and perhaps those that, for example, homosexuality is not acceptable. That certainly could be a very uncomfortable trend. Another very different domain that I've seen is sometimes people will have these intrusive thoughts of violent behavior or self-injurious behavior. For example, I had a patient who loved their dog and their dog was their entire world, but they'd have these very unpleasant thoughts of harming the dog or cutting the dog or killing the dog. And to be clear, this isn't somebody that I would consider by any means a violent person, a dangerous person, or a person that would engage in any behavior like this. But the thought that they have was so uncomfortable and it was so contrary to how they wanted to act or behave that it caused so much distress.
Yeah.
So that's one example, but I will highlight that there are many aspects of these intrusive thoughts that the patient doesn't want, the patient doesn't identify with, the patient doesn't value, or the
ego
patient,
dystonic.
It's very ego dystonic. By that we mean it causes distress. It's contrary to your own wishes or motives.
Which is literally the definition of something being ego dystonic. Dr. Baumgart, am I at any sort of risk for actually harming my pet?
I would say no. I would say it's clear that this causes it takes up a lot of headspace. For example, it causes a lot of distraction from what's in front of you, and it's clear it makes you very uncomfortable. So I would say if people have these intrusive thoughts, as we describe them, or these obsessions that are unpleasant, that it would warrant treatment.
Yes, absolutely. And I will tell you, I have had a lot of patients with complaints about, oh my God, am I going to harm something or somebody that I love? Am I going to harm myself? I had a patient that had harm OCD about himself, that he would be afraid to be around knives or stand on a balcony because what if I do something to harm or kill myself?
Right.
And my answer is always, Doc, are you worried that I'm actually going to do this? My answer is no. Have I ever seen that actually happen in practice where the patients actually engage in this behavior that is scaring the hell out of them? I haven't.
Usually not, because usually there is such a degree of fear and aversion to it that people are very aware that they want to do the opposite. But to bring back your point of being on a high area or a balcony, I think many people may identify with the experience of standing on a balcony and saying, what if I fall or what if I jump? And maybe that's a common point that many people and those that don't have OCD can identify as something that a thought comes into your mind and it's very different from your own desires to act.
Yeah. Now, one thing that's been particularly interesting for me to treat is relationship OCD. Doc, I'm in this relationship and I am completely obsessing about the fact that this person might not be right for me. Now, this one is so complicated because on one hand, they're in a relationship that is not right for them. They're obsessing about it, which is their obsession that this person is not right. But there's so much fear against them actually accepting that. And they're so defended against accepting that truth because what it means, AKA this relationship might have to end, that then they will pathologize it and call it a disorder so they can remain in the relationship and just label it and externalize it as a disorder versus someone that actually has relationship OCD and the person that they're with, they love, is actually someone that is wonderful for them, but they actually have this relationship OCD. Now, what do you have to say about that? It takes a lot. You have to really know the patient. I mean, this takes, a lot of work, a lot of nuanced questions, but have you run into this? And what do you think about this relationship OCD?
I think it certainly comes up. I think it's certainly a pattern for many people and many, again, successful people. And there's very many metrics of success, but having stable and functional interpersonal relationships is certainly one marker of success. I will say fundamentally as a psychiatrist, as a talk therapist, whatever role we're in, I don't give people relationship advice. And I don't think it's appropriate to tell people they should be with this person, they should not be with this person, they should do this with their life, they should make this decision. And some patients really want somebody who will tell them what to do. And to be clear, that's not good form in my professional opinion. What I would say though is you hope to attempt to build some insight about the symptoms. Are these intrusive thoughts? Are these obsessions you're having? Are these worries that you're having? Is this doubt that you're having? Is that reality-based? Is that appropriate? Is it not? Certainly relationships are, in my opinion, one of the most challenging aspects of our lives. Relationships are very complex. Relationships are very hard to navigate. And certainly it's easy to identify relationships that are going well and those that are going poorly. But for many people, there is a degree of a gray zone. So more than anything, I think my role when people are talking about their relationships is to consider, is this something that is in front of you? Is this something that's very realistic? Is this something that is excessive? Is this something that is unlikely? Is this something that does not have a clear, accurate appraisal of what the scenario actually is? And perhaps that's how you can identify some of these obsessive thoughts about relationships from perhaps realistic concern that one may have.
Okay. Social anxiety, what is it? How do you define it? Social anxiety.
Social anxiety is a type of anxiety disorder that's very characterized on one's interactions with other people. So I think it's important to differentiate social anxiety disorder from agoraphobia, for example. So social anxiety disorder is characterized by a pervasive, what that I mean by a chronic, enduring pattern of fear, of scrutiny in interpersonal situations with other people. What do I mean by that? I mean, oftentimes these individuals will have significant fear of saying something in a dialogue or a conversation or an outing that other people will find as being negative in some aspect. Oftentimes individuals with social anxiety disorder will have significant fear of scrutiny or appraisal or embarrassment in their interactions with other people, and they may avoid interpersonal relationships or opportunities for socialization due to this fear. Going back to agoraphobia, agoraphobia is more of a concern of fear of being in crowded places. Say, for example, subways, airports, Times Square, for example. And it often is more of a fear of crowded places, a fear that something bad will happen, perhaps, a fear that somebody will not be able to escape in a crowded place.
Not necessarily a negative judgment by someone.
Correct.
Yeah.
Correct. So it's more of social anxiety disorder is characterized by a negative judgment or a negative appraisal in your interactions with others rather than fear of possibly physical harm in situations of crowded places.
Yeah. And the language I always use for anxiety disorders, social anxiety. I am overestimating the chances of being negatively evaluated by another person, and I'm overestimating the severity of these consequences. Oh my God, they're going to think I'm totally weird. Oh my God, I'm going to be depressed. My self-esteem is going to suffer. They're going to tell their friends. No one's going to want to be friends with me. That's what social anxiety is defined as. What happens to a person when they're in a social setting and they're getting socially anxious? What is their experience? What happens to them in the moment?
People may worry. People may have ruminations, repetitive thoughts, unpleasant thoughts. They may withdraw from those environments. They may feel physically uncomfortable, notably some of the symptoms that we described earlier. And they may find themselves doubting their abilities. They may find themselves avoiding future interactions and missing out on perhaps opportunities to build social capital. By that I mean find new and meaningful interpersonal relationships. And it may come at a significant cost because it causes distress. And rather than focusing on this person who's in front of me, who maybe I have a lot in common with, maybe I think is a very interesting person, somebody who could be a friend, a colleague, somebody who could positively impact my life, I'm in my own head and I can't get out.
Bingo. That last point is so important. Now, those that are socially anxious, and even those that don't have social anxiety disorder, we can all get socially anxious in different situations. The attention, instead of being focused externally on the person that you're interacting with, often our attention gets focused introspectively, aka we get self-conscious. We start thinking about what we say before we say it. We predict that it's going to be evaluated in a negative way. We overly censor ourselves. We're not spontaneous. We don't take risks. We don't let our full authentic self come out. We don't make jokes for the fear that it won't land or be evaluated in a positive way. We get self-conscious. We overly censor ourselves. And one of the things that I work with patients on is controlling your breathing, regulating your body, and mindfully redirecting the attention externally on who you are socializing with. Self-consciousness in the context of social anxiety, I think, is a key term here. Where is your attention going? Usually too internally, too self-focused, with overly censoring yourself and not being authentic and spontaneous. Now, agoraphobia. Is the fear, this overestimation of a negative outcome, is it always a personal safety issue? Like what's the core fear of agoraphobia?
My understanding of agoraphobia and my experiences that I've had with patients who have shared symptoms of agoraphobia is typically the hallmark of crowds are dangerous. Being in public places carries risk. Being in places in which I'm around people that I don't know, that something bad could happen, perhaps there could be a loss of control, and I will not be able to get out of here alive, perhaps in some situations. So I think that agoraphobia has much more roots perhaps in one's physical safety versus social anxiety disorder, that there will be some aspect of my interaction that will lead to such a negative appraisal. Yeah. And I think certainly there's patterns where patients have both. They may have both. We'll talk about panic disorder in a little while as well, but agoraphobia was historically paired with panic disorder. And there certainly are many patients who, when they're in public places, if they have a fear of public places, may be predisposed to having panic symptoms. But people don't necessarily fit into all these categories, I think, is another point. So, you will have, I've seen many people that have themes of generalized anxiety disorder. Those have fear of crowds, those have fear of airplanes. And sometimes diagnostically it can be challenging, and you'll see multiple domains of fear that a person has. But I think these are common narratives and these are common threads that people experience.
Absolutely. And I asked Pat, what is the core fear associated with agoraphobia? When patients show up, often if you ask them, what are you afraid might happen? They can't even tell you. they haven't thought past the fear. So one of my techniques to try to get diagnostic clarity is lead them on a trail of, well, what are you afraid might happen? What are you afraid might happen? I keep asking, what are you afraid might happen until I get to the core fear? Social anxiety, again, the core fear is being negatively evaluated by other people and having negative consequences because of it. So that's a tool I often like to use to isolate diagnostically what's happening. Now, you're right. People don't fit into nice little boxes. The DSM is a guide, of course. Everyone is an individual. There's comorbidities. But for me, it's always important, even just to educate the patient and then come up with some sort of like therapeutic plan for exposures, for instance. What are you afraid might happen? So anybody listening, if you're feeling particularly anxious and you're not even sure what sort of outcome that you're afraid of, ask yourself, what am I afraid might happen? And keep asking yourself until you land at the core fear. Now, panic. What is a panic attack and what is panic disorder?
So panic in the professional sense is characterized by largely physical symptoms or physiological symptoms. So in lay culture, I think many people will equivocate many of these terms or interchangeably use these terms. Panic means I feel anxious, I feel uncomfortable. People will say I had a panic attack, and I'll often ask them, what does it actually mean? But in the professional sense, a panic attack is characterized by discrete episodes of intense anxiety, usually with various physiological symptoms. Some of the common ones include difficulty breathing, fast heart rate, feeling sweaty, feeling numb, and perhaps a sense of loss of control and a sense that something terrible will happen. Panic disorder is characterized by repeated periods of such. Oftentimes, these periods may not have a trigger, and oftentimes people will be very fearful about them happening again. And that is kind of the hallmark of panic disorder, is perhaps there isn't a clear event, perhaps there isn't a clear stressor, with the exception of perhaps agoraphobia, which is classically coupled with panic disorder. But these periods just tend to happen. And many patients are very distressed because they fear that they can happen at any point in time. They spend a significant amount of time worrying that they'll happen in the future. And they may engage in a significant degree of avoidance behavior with concern that, wow, this could happen at any time. I can't be in a public place when this happens. I can't be doing a lecture. I can't be interacting with somebody I don't know. I need to stay in my room and ensure I'm in a place that's safe, perhaps.
Yeah. A panic attack is a flood of fear. You have your adrenaline spike. It usually peaks within 10 minutes, usually self-resolves within 45 minutes. You have all of the symptoms that Pat described, well, some or all. You might get numbness, tingling. You might feel like you're dizzy or feel faint, this impending sense of dread or like you're going to lose control. Breathing often gets dysregulated. That's a panic attack. Panic disorder, like Pat was saying, one of the hallmark features is this fear that you will have an untriggered panic attack. It's fear of fear itself. I'm afraid that I will have a panic attack, and usually they will then avoid scenarios or situations in which having a panic attack is either embarrassing or having a panic attack it's hard for them to seek comfort. They might feel trapped somewhere. I'm at a dinner with people. I might be embarrassed if it happens. I won't be able to escape. I'm in some sort of big, large area, agoraphobia, where if I have a panic attack, everyone's going to see. How am I going to get safe and get comfort? Now, with panic attacks, with panic disorder, man, I have spent so much time talking to patients as to what's the trigger? What led to the initiation? What sparked off this panic? What you will often, not always find, sometimes you can't find the answer, but oftentimes the trigger for a panic attack is some sort of physical sensation that might cue you into thinking, oh my God, is this the start of a panic attack? Did my breathing just get a little weird? Did I get a little numbness or tingling? If some sort of physical sensation that most people would just ignore and say, hey, it's just my body doing like random body things, which happens, is this the start of a panic attack? That perceived threat will then set off a chain reaction because you're picking up this threat, catastrophe, it might be panic. My body gets aroused anyway. That feeds the fire, positive feedback loop, panic. So again, one of the hallmark features in diagnosing panic disorder is the fear that this will arise as I'm just getting about my business. It can be incredibly disabling. There can be a ton of avoidance behavior. It can lead to agoraphobia. And if anybody here has suffered from panic and panic disorder, you know how limiting it can be. And again, I know I keep saying this. We're going to go to the treatments in a second, but panic disorder can absolutely be treated. Now, Dr. Baumgart, panic attack, anxiety attack. What is the difference?
Some of this, again, is lay terminology versus professional terminology, and people may use these terms interchangeably. What I would say is when anybody comes to me and they say, I had a panic attack or I had an anxiety attack, I would try to get a sense of what are the actual symptoms? What actually happened? Did you have a discrete period that you had many of these physiological symptoms? Or was this a period of heightened worrying, intense worrying? And taking a step back from there can help you differentiate, was this true symptoms of panic? Was this more anxious distress? Was this obsessive rumination? There's a lot of different flavors, and certainly people will identify a panic attack or an anxiety attack is a period of some degree of very intense anxiety.
Yeah. The way I differentiate it, it's semantics, it's lingo.
Sure.
I don't think there's anything in the DSM that actually is called an anxiety attack.
Not to my knowledge.
Yeah. What I've seen just in kind of like lay terminology is just a timing and intensity issue. For me, like I said, panic attack peaks usually within 10 minutes, self-resolves within 30 minutes to an hour, whereas anxiety attacks can feel much more prolonged. Any other bits on panic before we move on to either talk about any other anxiety disorder you want or start diving into treatments?
One thing I'll say about panic is you need to exclude a cardiac event. You need to exclude a medical crisis, and certainly things like having sudden onset chest pain, difficulty breathing. For medical purposes, we'll make very many, people who don't have panic disorder, people who don't have anxiety disorders very nervous. So I think many patients with panic disorder will present to medical emergency rooms.
Oh yeah.
With symptoms. And I think it's important to note that while many people will find it very invalidating, perhaps, by that I mean they won't feel very heard or understood if they go to a medical emergency room and all the tests are negative, that can be a very important thing to exclude. So
Absolutely.
Certainly if you have sudden onset chest pain or difficulty breathing, especially that may be such that's associated with any sort of exercise or activity, certainly that's associated with any sort of breathing, post-digestion, for example, it can be important to exclude a medical etiology.
Yeah. The CNL doc bringing up an amazing point. As psychiatrists, medical doctors, we always want to make sure that there's not actually a physical etiology here, that there's not actually like an angina, some sort of like cardiovascular problem, some sort of lung issue. You bringing that up because, it can present with like chest pain. It can present with trouble breathing. I remember, not to personalize it, I rarely ever give personal information, but I remember when I first started actually intern year over at UCLA, I won't get into the details of the case. There's some sort of big challenge. It was quite anxiety provoking. And one night I get up and I'm just like having trouble breathing. I'm like, oh my God, am I having reflux? I popped a Tums. That didn't work. I can't lay down. I'm a freaking psychiatrist. Mind you, I'm an intern, but I don't know what the hell is going on with me. I was convinced I had a pulmonary embolism.
Right.
I couldn't figure it out. Actually, I think I might have been at I forget where I was, but I was at some wedding freaking the hell out that I was having a pulmonary embolism. It wasn't until my friend, one of my best friends who also has a panic attacks, told me, hey, Mike, maybe you're having a panic attack. I sought care, saw my psychiatrist, and sure enough, panic attack. So it can present in all sorts of ways. It's not always panic. Definitely make sure that there's not some sort of medical etiology. Pat was mentioning, like, does exertion cause you heart trouble? Are there any sort of like cardiovascular risk factors? Definitely make sure that you get worked up and that the diagnosis of panic and panic attack is accurate, an EKG and whatever else. Any other bits on panic? That's a great point.
I'll say again, I'll reiterate the point. Many people can find that invalidating or upsetting, but it's an important thing to exclude. And the fact that it's not an issue with your cardiovascular system, with your lungs, with your digestive system is a good thing.
It is a good thing. Often it leaves people more worried because they're like, what the hell? I thought I was going to get an answer out of this.
Correct.
Yeah.
But sometimes excluding bad illnesses, bad medical illnesses is something that you should refocus your thoughts and be very, I think, reassured about.
Absolutely. Now, we've covered generalized anxiety, OCD, social anxiety, agoraphobia, panic. Any other specific anxiety disorder you'd like to discuss?
There's various others. There's substance-induced anxiety disorders. So certainly, what do I mean by a substance-induced anxiety disorder? When you're using a medication or when you're using a recreational substance, alcohol, marijuana, cocaine, MDMA, methamphetamine, other drugs, either during times of intoxication or withdrawal, people can have symptoms of anxiety that may be associated with the substance itself. There additionally are specific phobias. So these are very narrow things that people may have a tremendous degree of fear about. Perhaps things like acrophobia, fear of heights, agoraphobia we already discussed, perhaps fear of arachnophobia. I think many people will identify fear of being on airplanes additionally. So I think some people will have very narrow aspects of their lives that they're fearful of, and some will have much more pervasive or more generalized patterns, as we discussed earlier, where basically everything in my life causes me fear. But I think that's a pretty good roadmap, I think, in many of the common things that people will experience. So if you have any of these fears, please don't be reluctant to reach out to your primary care physician, to a psychiatrist, to a talk therapist, because for many people, identification and treatment can be very helpful to your lives.
Absolutely. Now, if there's any anxiety disorders we didn't cover, you guys can leave them in the comments. We'll get to them next time we bring Pat on. Quick question, and I don't want to dive into this because we're going to have another podcast specifically about this, but PTSD, can that be considered an anxiety disorder? The fear is the engine that drives post-traumatic stress. You can often see avoidance behavior and catastrophic thinking. You can see, like OCD, responding to a threat despite the context. I'm in a normal cafe. I'm afraid of my physical well-being. My back is against the wall. Or OCD, I'm cleaning a clean room despite it being completely clean. Is PTSD an anxiety disorder?
So post-traumatic stress disorder is an entirely different umbrella, but it is something that has very common themes, I think, with many other anxiety disorders. And patients with post-traumatic stress disorder, assuming you've had a criterion A stressor, and by that I mean you have some sort of life event that you perceived or understood as being significantly damaging to your health, things like physical violence, murder, rape, natural disasters, etc., causes a tremendous amount of fear in many patients. I will often refrain from concurrently diagnosing an anxiety disorder when a patient has a clear post-traumatic stress disorder because there is a lot of overlap in the symptoms. That being said, I mean, it's certainly possible you may have had general anxiety disorder your entire life and then you experience a trauma and now you have symptoms of post-traumatic stress, but it can be a bit murky.
Yeah. Now, I'll refrain from diving further into this because we're doing an entire podcast on post-traumatic stress upcoming. If the audience has any questions, you want answered when we film the PTSD episode, you can leave them down below. But let's dive into treatments for anxiety disorders. Let's start with the medications. Maybe we'll go one by one and you can say what you do for each diagnosis that we discussed. And then we'll get into therapy and different therapeutic modalities for treating anxiety disorders.
Great. So with many psychiatric diagnoses and anxiety disorders being a hallmark of such, there are multiple treatment options. And it's important to note that the treatment options that are available are evidence-based. They work for many people, but different things work for different people. So when we think of treatments for anxiety disorders, kind of the two main modalities that we offer, at least from a professional setting, usually include a possibility for talk therapy, psychotherapy, and psychotropic medications or pharmacological treatment, as people will describe it. Those are the two main umbrellas. Certainly there are other treatment modalities that I think are very important. Certainly things like exercise, wellness, meditation, engaging in hobbies that are meaningful for you are things that patients can include on their own. Certainly things like faith for people who have religious faith can be very powerful and can provide a meaningful sense of hope. Certainly social support and sharing this with your loved ones and having them on your side can be very helpful. So those are things that I'll reiterate to the patient to perhaps consider outside of our appointments and consider in their own time. While in the appointments, we will usually offer a combination of talk therapy, psychotherapy, and psychotropic medications.
And relying on others is very important. We're going to talk about loneliness towards the end of today's podcast, but let's dive into the main foundational classes of medications that we use to treat anxiety disorders.
So there are many, and I think many people who are not seeing a psychiatrist may be familiar with many of these. So there are antidepressants such as SNRIs, SSRIs, TCAs, for example.
Tricyclic
antidepressants are other classes that may be helpful. Certainly benzodiazepines, many patients will be familiar with. These are medications like your Xanax, Klonopin, Valium, that people may be familiar with. Certainly antihistamines may be helpful. These are medications that include things like diphenhydramine, hydroxyzine, cetirizine that are also used for allergy treatments. Certainly things like your adrenergic alpha-2 agonists, such as guanfacine, clonidine may be helpful. Those are a few medications that probably are most frequently prescribed that come to mind.
Okay, now let's talk about at the start of the podcast, you brought up a case example with, I believe it was a female, generalized anxiety disorder, having insomnia, muscle tension, gastrointestinal issues. Can you give us a sense of what the medication plan was for this woman?
So for many people, assuming that they understand their symptoms, assuming that they want treatment for their symptoms, assuming that they're interested in taking a medication.
And they're here to see you.
Correct.
And you're a psychiatrist, a psychopharmacologist. So we can assume
hopefully we're already
they're
there.
Open for that.
Hopefully we're already there.
Bingo.
I would consider first and foremost with starting with an SSRI antidepressant.
But doc, I'm not depressed. I'm anxious. Why would I start an antidepressant?
So it's important to note that antidepressants, while they're characteristically understood as being for depressive disorders, mood disorders, they confer benefit for a large number of other disorders, including anxiety disorders, including post-traumatic stress disorder, and some antidepressants may be used specifically for sleep alone. For sleep may have many etiologies, including anxiety, depression, but sometimes just classic insomnia. Antidepressants can be helpful for sleep.
Yes, so it's a misnomer. The antidepressants, sorry to interrupt you, are used for all sorts of reasons outside of just depression.
And I think that's important to identify. And certainly whenever somebody's coming to me and maybe it's the first time they've ever taken medications, I think it's important to disclose the class of medications. Sometimes people will be very confused about, for example, why they're taking a specific class of medications that are identified as something. Another example would be an antipsychotic. So antipsychotics may confer benefit for things like sleep and with mood disorders as well. So having that conversation can be important. But antidepressants, I believe, especially SSRIs, are perhaps the best starting point for patients.
Absolutely. So this patient, give me a sense of like what you did for her pharmacologically?
So we started sertraline, brand name Zoloft, which is perhaps one of the most commonly prescribed antidepressants. So we started a small dose of the medication, maybe
give the audience the dosages. They want to hear
25, 50 milligrams, and we would up-titrate the medication based on their symptoms. So it's important to note that antidepressants will take time. A lot of people with anxiety disorders, they feel uncomfortable. You want a solution now. While there are some medications that may confer benefit as quickly as 30 or 45 minutes after you take the medication, for example, antidepressants don't. They take time. They often take, we consider, 4 to 6 weeks, maybe even longer at a specific dose before you get the maximal benefit. So I always encourage people, you have to take the medication daily. You may not notice anything immediately, and we may require several dose adjustments until you get to a point where you're feeling better. And I know that can be a tough pill to swallow because a lot of people want to feel better
Not
now.
literally.
Not literally, but metaphysically, I guess, right? So it's important to note that a lot of anxiety disorders typically will require high doses, kind of towards the FDA max of anxiety disorders. So anxious people will be anxious about medications, and anxious people will want solutions today. And I understand it. You feel uncomfortable. You want to feel better. You want something that works. But I always encourage people to give it some time. For many people, SSRI antidepressants make a significant benefit. They are medications that prevent anxiety. They don't abort anxiety when you're in the middle of a crisis.
Bingo. Dr. Baumgart, why the hell do these medications take so long to kick in?
I wish I had a magic bullet, I would say. But for many patients, we can consider a trial of an SSRI. I'll encourage people to have a buy-in that basically we have an understanding that, assuming that you're not having any side effects from the medication, that it's well tolerated, that you take it every day for at least a couple months, and you will probably get some benefit. Additionally, for many patients with anxiety disorders, we may start a medication that you can take on an as-needed basis that will provide you relief today.
Yeah. Now, SSRIs, fundamental first-line treatment for anxiety disorders. There's actually evidence out there that anxiety disorders are more effectively, there's a higher chance of successfully treating anxiety disorders with the SSRIs than actually major depression. They take up to, 8 to 10 weeks to really get the full benefit. One thing I like to do is, especially if there's an insomnia component, always address the sleep concurrently as we onboard the SSRI. Now, benzodiazepines, like some of the ones that Pat mentioned, are vilified these days. Doctors are afraid to use them. That's why you go to a psychiatrist, right? This is in our wheelhouse. So SSRIs are absolutely the foundation for treating anxiety disorders. Like Pat was saying, it takes weeks for the effects to kick in. And we have all sorts of data points. Those people that follow my Instagram have seen me talk about this. We know what symptoms of what disorders go into remission at different dosages. Your mood disorders, typically like major depression, typically can be treated with low to medium doses. But like Pat was saying, with anxiety disorders, specifically like OCD, for instance, or panic, we often need to get to the FDA-approved max or even higher to successfully put anxiety disorders into remission. Now, Doc, why does it take so long for these to kick in? Now, you take your Zoloft every morning, the serotonergic tone in your brain goes up. We know that monitoring on a daily basis, that serotonin in your brain goes up on a daily basis. But it takes time of taking the medication every single day to kind of quote unquote rewire your brain, re-regulate the receptors in your neurons. It takes time. Now, in an inverse way, people can appreciate that, hey, if I have alcohol for one night, which is a psychotropic, substance, I feel X amount of way. If I'm drinking alcohol every day for 2 months straight, the effects are going to be particularly different than if I took it on a one-night basis. Things that are psychotropic in nature and change your neurochemistry, taken daily for X period of time, can have different effects than if you take it just one time. Now, what Pat was saying, a lot of anxious people have a sense of urgency to feel better. So take this example that Pat brought, right? This generalized anxiety disorder female, she's having insomnia. We start a Zoloft titration. We start usually at 25, maybe go 50, even higher. The FDA approved max is 200. But I will often also bring in another agent, for instance, like a hypnotic agent or a sleep agent, to try to provide more immediate relief as the effects of the SSRI kick in. There are all sorts of beautiful studies out there, for instance, that show that if you start lorazepam, Ativan nightly for the first 2 to 4 weeks as we load up on the SSRI, we get better, faster results that remain even after we taper off the benzodiazepine. So this is one of the reasons you go to see a psychiatrist. There are strategies that we use to give the patient more relief faster. We have a comfortability with these medications. We utilize them all the time. And, we're going to get into benzodiazepines when we get to the Q&A section, but they can absolutely be used in an amazing way. They can be amazing medications, but they can also be an absolute nightmare. Now, that's my little 2 cents as far as this case example. Anything else? Well, how else did you treat? How far along in the treatment is this female? Tell us more about her treatment.
Yeah, so she's somebody that I've been seeing for, I don't know, maybe about 6 months or 9 months or so. And now she's on a high dose of...
What dose?
200 milligrams of the sertraline. And she's reporting to me that she feels much better. Concurrently, we do have her on a hypnotic. We have her on trazodone, which is an antidepressant, which is a non-habit forming, probably a pretty common choice for many patients that have difficulty with sleep onset. It's also classified as an antidepressant, but in many situations it's prescribed purely for sleep onset purposes.
And sleep maintenance, actually.
And sleep maintenance, sure. So, the reason why I bring up the issue of sleep onset is many patients with this anxious distress will find that all their worries come out, all their intrusive thoughts come out when they're lying in bed at night. Certainly, people can wake up and feel very anxious, very panicky, but I think really a very common difficulty with sleep is the sleep onset. So
Absolutely.
Finding something that gets you to sleep is very important.
Especially in insomnia secondary to generalized anxiety disorder. And for the audience listening, a hypnotic agent is one that it's a sleep medication. Now here we talked about GAD. Talk to me about OCD. Is there any sort of difference in how you treat obsessive compulsive disorder versus a generalized anxiety disorder? Talk to me about OCD treatment pharmacologically.
Yes.
We'll get into therapies in a moment.
Yeah, so typically obsessive compulsive disorder may require and may benefit from higher doses of serotonergic medications. By that I mean SSRI antidepressants and perhaps also the tricyclic antidepressants. So oftentimes patients with obsessive compulsive disorder may benefit from exceeding the FDA max. I know some people may have some concerns. Why am I taking this medication? The Food and Drug Administration suggests that this is the maximal dose. What I'll say is this is certainly a guide, and FDA maxes may be identified on the basis of what the medication was authorized for in the first place, the patent in the first place, such as a mood disorder. We understand that you can take a higher dose of an antidepressant, and it may certainly be very safe, and it may confer significant benefit for obsessive compulsive disorder. So certainly a higher range of an SSRI, we're using the example of sertraline, for example. I've had patients that are on 225 milligrams, 250 milligrams, maybe up to 300 milligrams. Certainly other medications may be of specific benefit or specific choice for patients with OCD. Fluvoxamine, brand name Luvox, is a common selection. And going back to the tricyclic antidepressants, clomipramine is a medication that historically was used and may still be used for patients with obsessive compulsive disorder.
AKA anafranil. Dr. Baumgart, what is the difference between a tricyclic antidepressant and an SSRI? What is that?
So a tricyclic antidepressant is a medication that affects more neurotransmitters. So by neurotransmitters, I mean different chemicals in the brain. So a tricyclic antidepressant may affect the regulation and the movement between nerve cells or neurons of dopamine, norepinephrine, and serotonin. An SSRI, or a selective serotonin reuptake inhibitor, specifically targets the action of serotonin. So a tricyclic antidepressant may have more effects. I think a tricyclic antidepressant may have potentially more side effects. A tricyclic antidepressant may have some safety concerns and overdose or with certain medical conditions. So in some cases, they've fallen out of favor. SSRI antidepressants are generally more commonly prescribed and medications that I would certainly start with.
Yeah. And interestingly, one of the reasons that the SSRIs are more favored than the tricyclic antidepressants, were a little bit older, is that the amount one would have to take of an SSRI to get toxic and have potentially fatal consequences is insanely high. So when we're prescribing these medications specifically to like majorly depressed, perhaps suicidal patients, it's much safer to give them a bottle of pills like SSRIs that can't actually be used as a tool to attempt or commit suicide. The tricyclics you have to watch out for. At too high of doses, there can be cardiovascular issues, arrhythmia issues. There's certain patient populations that have arrhythmias that we do not want to use TCAs with. That being said, are tricyclics the first line I go to treat OCD? No. But do I go to TCAs like clomipramine, aka anafranil, if the SSRIs have been exhausted? Yes. Now, fluvoxamine is interesting. It's generic now, but it's newer than Zoloft and Prozac and Lexapro. How often are you using fluvoxamine? What about it do you like? Talk to me about fluvoxamine. And also, what dosages do you like to go to for OCD with fluvoxamine?
I think fluvoxamine is more selectively used for patients with OCD. I would say in my own practices and my own education, I would probably start with Zoloft or Lexapro. I think they're medications that are very well tolerated. They're commonly prescribed. They have fewer drug-drug interactions, for example. But with fluvoxamine, certainly can consider 50 milligrams, 100 milligrams, 150 milligrams. Like any medication, different doses may work better for different people. So good form, common strategies are to start at a starting dose, and you'll up-titrate. By that, I mean you'll increase the medication in response to somebody's symptoms. So typically, I would start at a starting dose, maybe for anxiety disorders, depending on the comfort of the patient. I may be more conservative or more liberal, but you're going to check in with the patient, see how things are going with the medication, consider an increase. And basically what you want is either a response or remission of symptoms. You want a reduction of symptoms and optimally a resolution of their symptoms.
Yeah, absolutely. And what Pat was saying is OCD is one of the disorders. Another one is bulimia, for instance. And we're going to be releasing a whole podcast on eating disorders soon, where you really, really want to push the SSRI to a high dose. If you look at niche OCD literature, they will push Zoloft, which FDA-approved max is 200, to 250, 300. Fluvoxamine, 200, 250, 300. A technical, legitimate treatment of OCD is a high dose of an SSRI for 3 months. So if you have OCD, it takes a higher dose for a longer period of time to put the symptoms into remission. And you have to explain that to patients from the start. Like you said X amount of minutes ago, you have to set the expectation. You don't start the fluvoxamine at 50, they come back, okay, let's go up. Hey, let's go up. Hey, doc, why do we keep having to go up on the medication? It's not working. What the hell is happening? You set the expectation up front. Listen, Joey, fluvoxamine, we're starting at 25. Do not be surprised if we get between 150 and 300 and stay there for 3 months before we can expect like a real true response to your OCD. Expectation setting is absolutely paramount, particularly with patients that are clinically anxious. I've started this medication, it's not working. Oh my God, what does that mean? I'm on a higher dose. Does that mean I'm more severe? It can really be the source of a lot of fear and worry. So set the expectations early, everybody. Now, before I let you, jump in, and then I want to talk about Prozac, but what were you about to say?
No, I was going to say, I always encourage people, if you don't feel the medication is doing anything, if you're not having problems with the medication, you're taking the medication, you're not getting a response from the medication, there usually is no risk for increasing the dose. And I know many people have concerns, and there's a lot of misnomers about antidepressants that I think are out of the scope of this talk, of getting addicted, getting habituated, concerns about coming off antidepressants. But what I'll say is, if you're having no response and no difficulty, there's a lot of upside to increasing the medication.
Absolutely. Now, Prozac is an interesting one. It's one of my favorite antidepressants, but you mentioned Zoloft and Lexapro first. One of the reasons you said that is those don't cause major interactions with other medications. Prozac is interesting. It has a very long half-life. So once you've been taking the medication for a period of time, your blood level remains stable. If you miss a dose, you're not going to really notice it. It is a 2D6 inhibitor, which is an enzyme in your liver that metabolizes all sorts of medications. So there's all sorts of interactions with other types of medications. And Prozac is an activating SSRI. Do you ever keep in mind the fact that Prozac can be activating and has a little bit more of a risk of like agitation or insomnia or activation in utilizing it for an OCD patient? Does that ever cross your mind? Is the activation risk significant enough for that to be a component in your decision-making for choosing a medication?
I think it's variable. Certainly, we consider different SSRIs have different characteristics and qualities. For example, we think of fluoxetine, brand name Prozac, as being one of the more activating or energizing SSRIs. We think about paroxetine or brand name Paxil as being one of the more sedating SSRIs. Different people experience medications differently. Sometimes, and many of the other SSRIs are in the middle. Sometimes patients with anxious distress will get more anxious with an activating antidepressant. Sometimes they'll feel much better.
Yeah.
So I think following the clinical response, getting a sense of what's worked for patients, and individualizing your treatment plan is good for them.
Yeah, individualize is right. I use Prozac first line to treat OCD all the time. It's individualized. If a patient is complaining that he's feeling like fatigued, he or she is feeling fatigued, perhaps I'll utilize that activation of the Prozac. If I have a patient that's like on the go, on the move, traveling a lot, doc, I can't reliably take a medication every 24 hours. I don't want to be tied down. What if I'm traveling? My effects are, I missed a dose, I felt like crap. The Prozac gives them a little bit of a longer sort of leash here. So Prozac can absolutely be used to put OCD in remission. I do it all the time. And so those are the SSRIs, right? Now, a common question I get is, doc, can I use SNRIs, serotonin and norepinephrine reuptake inhibitors, in anxiety disorders? And then the follow-up question is these things are increasing norepinephrine, which increases arousal states. Won't that make my anxiety worse if it's increasing my arousal? Why would these be used in anxiety disorders? There's FDA indications to use SNRIs in anxiety disorders. What do you say to these patients that ask this question?
Certainly, SNRIs, serotonergic norepinephrine reuptake inhibitors, have a less selective action. So they additionally have the aspect of serotonin. SNRIs may confer significant benefit for a wide range of reasons. And specifically, we may use them in patients who have neuropathic pain concerns. So what do I mean by that? I mean patients that have nerve-related pain. So sometimes the anxiety may come from medical symptoms, medical etiologies, being in pain. And I would say, and certainly in cases like that, it may confer significant benefit. Additionally, different medications, again, will work for different people. So I've had some patients that will take an SNRI, will feel more anxious, and some patients that will not. So it is variable, and I think certainly the pharmacologic aspects of the medication is more complex than we simply distill it down to norepinephrine causing people to feel more anxious. And certainly the brain is the final frontier.
I struggle to think of when I have a patient come in, they're medication naive, they haven't tried anything. I don't think I ever really start first line with an SNRI. The side effect profile differs. The SNRIs in the first week or two, there's a little bit more risk of feeling agitated, having insomnia, having elevation in heart rate. But what's important is that with anxiety disorders, it's not always that your just tonal level of norepinephrine is too elevated. It's not as simple as that. It's a dysregulation. So when the norepinephrine component comes in, it can actually help regulate the entire system. So short answer, SNRIs can absolutely be used in anxiety disorders. Yes, there might be a risk of having a bit increased anxiety in the first couple weeks that's higher than a pure SSRI. But they can absolutely be used to treat primary anxiety disorders, SNRIs. And they do have great benefit, evidence-based, for treating neuropathic pain like Dr. Baumgart was mentioning. Buspirone. What is buspirone? When do you use it? Does it actually work? What is buspirone?
Buspirone is a medication that affects the regulation of serotonin in the brain. It's a medication that people will take on a standing basis that is non-habit forming, that may provide or confer benefit for anxiety disorders. Oftentimes, I would say if somebody is presenting with initial symptoms, I will try to optimize them with an SSRI, maybe even an SNRI, and then I may consider buspirone or another agent as an augmenting agent or a medication that I would add on to try to target residual symptoms.
Propranolol, beta blocker. What is it? What does it do?
So beta blockers are medications that are classically used as blood pressure medications. Beta blockers may either be cardioselective or non-cardioselective. By that I mean they may either affect only the heart or the entire body. Propranolol is specifically used for performance anxiety. It can certainly help with more of the physiological symptoms, the physical symptoms, the muscle tension, the discomfort that people talk about. And sometimes it's used as an as-needed medication when people are about to be in a situation perhaps that they need to perform well. We talked about social anxiety disorder. Perhaps I'm going to give a big talk in front of a lot of people and I feel nervous. I take the propranolol 30 minutes before and I feel less physically heightened or on edge.
Yeah, bingo. Now, beta blocker. They are blocking the beta receptor. This is one of the receptors that adrenaline and noradrenaline bind onto to cause their physical manifestations. The beta receptor is the receptor on the heart where adrenaline binds to cause it to pump harder and faster. It's implicated in that nervous breathing, trembling, sweating, muscle tension. So beta blockers are fantastic for performance anxiety specifically because they can help relieve this tension, these physical symptoms, while maintaining clarity of thought. They don't have the risk of sedation that a medication like Xanax or Ativan or clonazepam have, for instance. This is why they're famously used for performance anxiety when you have to maintain a clear head and cognition, but you're feeling that tension in your body. You mentioned cardioselective and non-cardioselective. What's important for everybody that's on beta blockers or the providers out there that are prescribing beta blockers, one thing you want to watch out for is evaluating or screening for a patient that has a history of asthma. If someone has a moderate asthma or even a mild asthma, especially if they have any sort of asthma medication or require an emergency inhaler, non-selective beta blockers can exacerbate asthma. We mentioned how they can impact the receptors on the lungs that cause anxious breathing. So definitely turn to the cardioselective beta blockers and not propranolol in a patient that has performance anxiety that wants a beta blocker. You really do not want to risk an asthma exacerbation.
And I think that's an important note. So a beta blocker causes what's called bronchoconstriction. What do I mean by that? That decreases your ability to engage in appropriate air exchange at the level of the lung. So many asthma medications are dilators, bronchodilators that do the opposite effect. So certainly screening for asthma in a lot of patients that have asthma will have anxiety disorders. A lot of patients who have difficulty with breathing will feel very anxious, whether it's clinically excessive or clinically distressing or not. But that's an important point and something to exclude.
Yeah. And one of the cardioselective beta blockers, meaning the beta blocker is only working on the heart. It doesn't have the same robust effect as the propranolol because it's not helping with the anxious breathing. It helps with that harder and faster heart rate, is atenolol. That is one example. Now, let's dive into Benzodiazepines. Give us a quick rundown. Maybe tell us the differences between Xanax, Ativan, Klonopin, and Valium. When do you use them? And tell us about these benzodiazepines.
So benzodiazepines are a class of medications. They're classified as sedative hypnotics. By that I mean they cause you to feel calm. They may cause you to go to sleep. Pharmacologically, they work on the GABA-A receptor, GABA-A antagonism. So in a similar function that alcohol works on the brain, in a similar function that another class of medications known as barbiturates work on the brain. Mm-hmm. So they exert a calming effect. Many people like benzodiazepines because they are immediate in nature. So you take a benzodiazepine and you may feel calm. You may go to sleep within a pretty short period of time, maybe 30 minutes, 45 minutes, 60 minutes, depending on the action and the half-life of the specific medication.
Yeah, and also depending on the dose, because you can also take a dose small enough to calm you, but keep you alert and not put you to sleep.
Right. Similarly to drinking alcohol, I think many people will experience, having a drink in a social situation helps me feel calm, but if I drink excessively, I will pass out, right? So it is a titratable effect, but benzodiazepines are a medication that may provide immediate benefit for anxiety disorders. They provide that abortive treatment for anxious distress we talked about. So I'm in crisis right now. I can take this medication. It will likely work within that time frame I already discussed. So many people find the benzodiazepines to be very beneficial. Benzodiazepines, unfortunately, are a medication that are quite polarizing for a number of reasons. They do carry more risks than many of the other medications that we have discussed, but it's important to note that they are very effective and they can reduce the amount of distress that a person is experiencing. Specific concerns with benzodiazepines may include things like such as sedation. They may have what's called anterograde amnesia, which means after you take the medication, you can't remember what happened. Blacking out with alcohol. They may cause difficulty with coordination. They may cause sedation. They may cause respiratory depression and even death, similarly to drinking excessively. Especially carry risks in patients that have various medical comorbidities, certainly with patients that are on concurrent medications, such as opioid pain medications, have significant risks for sedation, respiratory depression, and death. And certainly if people are drinking, using barbiturates or other sedatives, they carry the same risks. On the other side of the coin, benzodiazepines in the long term tend to lose their efficacy. People get habituated to them. So if you take the benzodiazepine every day, it doesn't tend to be as effective. It wears off. You need a higher dose of the medication. And unfortunately, they do carry risks of dependence. So people get addicted to them. They are very difficult to stop. So I think this creates a landscape of a lot of positives, a lot of negatives. Certainly, these medications are under close consideration by your medical professionals. They are monitored by the Drug Enforcement Agency. So a lot of patients will understand that benzodiazepines are a pretty loaded topic.
Absolutely. Used appropriately and judiciously, they're fantastic, but carry risk. Used inappropriately and too liberally, they can be an absolute nightmare. Now, what Dr. Baumgart was saying is you really want to be careful with these medications. Benzodiazepines, it slows everything down. Now, if you start stacking other things that slow you down, depressants like alcohol or barbiturates or opiates, that part of your brain that keeps you breathing might get slowed down to the point where you literally die. So when we're prescribing these medications, we always need to know, are you on any other depressant medications? Are you on opiates? What sort of alcohol are you using? And when we prescribe these medications, I painstakingly make it absolutely clear that there is no drinking on these medications. The last thing we want is for someone to get over-sedated and, God forbid, have some sort of like apneic respiratory depression and event that can cause them major problems and even death. Also note, if it's your first time taking a benzodiazepine, please do not get behind the wheel of a car. These things can be quite sedating, quite altering, can put you off balance, slow your reaction time. So really, they have to be prescribed and utilized in a very cautious way at the hands of a trained professional. And typically, for a short period of time? Are there patients that I manage long-term on a benzodiazepine and they're well managed, they don't get desensitized, they don't need higher doses, and their symptoms stay in remission? Yes. Is that typically an exception to the rule? Yes. Now, what other medications do you think are pertinent to talk about as far as anxiety disorders?
Antihistamines such as hydroxyzine, brand name, maybe Vistaril or Atarax may be commonly prescribed. Gabapentin.
What is that? That's a common medication. Sorry to interrupt you, but give us a bit on that.
Yeah, gabapentin is a medication that often is used for neuropathic pain and seizures. It's a medication that does not affect the GABA system, but it can be very helpful in terms of reducing the physical arousal of anxiety disorders. It can help with sleep. So if I have somebody who comes to me and they have significant pain-related concerns, they have anxious distress, generally isn't marketed. Well, it is marketed originally, but it's not generally used for seizures, but perhaps they have a seizure disorder. It can be a medication that can help with many of those aspects. It is controlled, but not to the same schedule of a benzodiazepine or a stimulant. And it can be something that is a better long-term agent, especially if people have those pain-related concerns.
Yeah. And one thing you'll see is that a lot of medications that we use to treat anxiety can be used to treat neuropathic nerve pain. So it's funny to say, but they literally calms your nerves, right? I mean, what is anxiety? It's a bunch of nervous tissue circuits in your brain just firing off. So people will tell me, well, doc, why am I taking this gabapentin? It says it's for nerve pain. I don't have nerve pain. Doc, why am I taking this medication? It says it's for seizures. I don't have seizures. Seizures, boom, dysregulated neurological activity. Nerve pain, dysregulated neurological activity. Anxiety disorders, dysregulated neurological activity. So do not be surprised if one of the medications that your prescriber gives you for your anxiety disorder and you Google it, it says it's used for treating seizures or nerve pain.
Correct. And many medications that are used for psychiatric purposes and neurological purposes may confer benefit for both, right? So we traditionally think of the brain and the mind being two separate things, but we all know, in fact, that that's not the case, and it is more complicated than that.
Yeah, and the soul is a philosophical discussion, perhaps for another topic.
It is. It certainly is, Dr. Mah. But keeping in mind, though, I mean, the brain and the mind are one common thing, and I always encourage people not to get caught up in the actual classification of medications. Again, an antidepressant may confer benefit for an anxiety disorder. An antipsychotic may confer benefit for a mood disorder. A medication that's identified as an anticonvulsant or a seizure medication may help you with many different aspects of your mood.
God, I wish they didn't call them antipsychotics, because every time I want to use them, patients freak out. I'm like, you're not psychotic. We're using Abilify at 5 milligrams. If you were psychotic, it'd be at 20, 25 milligrams. Antipsychotics, if your doctor's trying to prescribe you antipsychotics, do not worry. Most of the time, well, I don't know the statistics, but at least a large portion of the time that antipsychotic medications are used, it's for mood and anxiety and sleep and has nothing to do with you being psychotic. So no, your psychiatrist does not secretly think that you're psychotic and trying to pass you off these medications. Neuroleptics would be a better, I suppose, more benign name for these antipsychotics.
Right.
Yeah.
Another class of medications that can be helpful for anxiety disorders, we talked about the alpha-2 adrenergic agonists, such as guanfacine, which may be brand name Intuniv or 10X or clonidine. These are medications that essentially will calm down that central hyperarousal, the adrenergic system that causes the edginess as well. So sometimes that can be a good adjunct as well, a good medication. But again, at the end of the day, with all the medication options that we have, it is something that you can tailor to the patient. And
exactly. Do you want to target the alpha system? Do you want to target the beta system? Do you want to increase serotonin? Do you want to increase serotonin and norepinephrine? Do you want to give them some sort of hypnotic agent to go to sleep? And then all the rest of everything you mentioned as far as like holistic care with everything else. Now, anything else on medications? We're running out of time. Dr. Baumgart has to be in clinic. What should we know as far as therapy options for anxiety disorders, generalized anxiety, but specifically OCD and panic and everything we talked about? Therapeutic modalities, therapy options for anxiety disorders.
Therapy is very important. and I always encourage people to not overlook therapy. We understand medications and psychotherapy as both conferring benefit. The evidence demonstrates that certainly the average person will do the best if you combine both modalities. Some people prefer talk therapy, some people do better talk therapy, and some people will do better or prefer medications. Some specific therapies that may work well for patients with anxiety disorders, certainly you can consider cognitive behavioral therapy, which examines the relationship between thoughts, your emotions, your feelings, actions, and also exposure and response prevention, essentially, which basically you address the issue that's making you anxious and you try to prevent or deregulate or decrease the severity of that pathological worry or physical symptoms that you may experience when encountering something that is distressing.
Okay, now we're running out of time. As far as talking about like current events and loneliness and the pandemic, we're going to bring Pat back for that. I want to ask you, what are some tools one can use when they're experiencing an anxious arousal or panic to get themselves out, or just really heightened anxiety? How do you manage that in the moment? Once you answer that, we'll do some Q&A and then we'll wrap it up for today.
So there's many things. Certainly, perhaps the easiest that I would consider might be boxed or square breathing. So people can
square breathing.
People can really slow down their breathing and focus on their breathing. What do I mean by that? 1 second increase to inhale, maybe hold your breath for 2 seconds, and then exhale and focus on that time frame. I don't know if that's a square or a rectangle, depending on your respiration rates, but slowing down and focusing on your breathing can be very grounding for many people. Additionally, doing something like mindfulness. So mindfulness is the act of focusing on your immediate surroundings, trying to remove yourself from these worries or thoughts or preoccupations or obsessions about past and future. Things such as progressive muscle relaxation. There are many online YouTube scenarios that can walk you through essentially meditative techniques to relax your body from head to toe, for example. Other meditative modalities certainly can be helpful for people. Worship or faith, if that's something you're into, can be helpful for many people. Things like exercise, I think, are paramount. Engaging in those activities. I love playing electric guitar, for example. That can be something that's grounding for many people.
Distraction, yeah.
Yeah, something that is meaningful for you and calming for you can be helpful.
Now, I'm glad you started with the breathing techniques, because always I tell patients, when you're losing control of the mind and you're getting this sense of dread, this sense of panic, and your body's getting into this arousal state, sometimes when we're losing a grip on the mind, it's hard to control the mind with the mind. So let's start with the body. Breathing for me is always number one. Now, when we're getting anxious breathing, when our breathing gets dysregulated in an anxious moment and we have shallow, quick breaths, the composition of like our oxygenated blood and like the carbon dioxide in our body, in our blood, changes. Literally the physical makeup of what's going on in your bloodstream and all the other tissue changes because your carbon dioxide goes up, and that alone can perpetuate an anxious arousal. Starting with this boxed breathing, control your breathing is step one. After that, any sort of technique that you mentioned, fantastic. Mindfulness meditation is that's one of my favorites. Now, you can't just turn to mindfulness in the moment because you're freaking out and you're anxious and you're panicking. You have to learn how to practice mindfulness, a daily practice. Now, there's specific apps I use. Waking Up by Sam Harris is one of them. No, he's not paying me to say that. Sam, if you want to, you can leave a comment below. But what is mindfulness? I mean, there's so much to say about it, right? If nothing else, it's attention control practice, right? Thought comes up. What's useful in this thought? Let me not judge myself for having it, and allow myself to let the thought pass so it doesn't hijack my attention, and I can reorient my attention to the present, to something to distract me, or whatever. You're gaining more control over your own attention. you're gaining a greater sensitivity to what's happening in your field of attention. A daily mindfulness practice is useful for quite literally everything. So yes, breathing, practice your mindfulness. You're welcome to distract yourself, seek the comfort of a loved one, and the list goes on. But to me, it also starts with breathing. Any more on that before we turn to questions from the audience?
I think those are good general guidelines, and there's a lot of information about this online.
Yes, absolutely.
On YouTube or professional sites, I welcome anybody to investigate these options, and these are good treatment options that certainly are evidence-based.
Yep. Audience question number 1, Dr. Baumgart, can I smoke pot? It helps calm me down. Yes, once in a while I get a little bit more hyperfixated on my problem and get anxious, but I'm smoking weed. It's helping me. It's medicinal. I know I have a clinical anxiety disorder, but this is one of the treatments I choose to use. What do you think about pot use in anxiety disorders?
I always encourage people to be forthcoming about their substance use, regardless of what it is, regardless of if it's tobacco, alcohol, marijuana, cocaine, methamphetamine, MDMA, psilocybin, for example, LSD, other drugs, so we can have an honest dialogue about it. I think that many people will use pot and attempt to calm down and attempt to go to sleep, and it can effectively calm people down and sedate them when you're intoxicated, right? After you smoke, after you have your edible. We know that habitual marijuana use does have withdrawal symptoms. We do know that habitual marijuana use may result in withdrawal, symptoms of poor appetite, symptoms of anxious distress, symptoms of insomnia. So many of the withdrawal symptoms of marijuana use may exacerbate one's anxiety. And certainly if you're habitually using marijuana, it may contribute to a worsening anxiety disorder. I know marijuana is something that has been described by different agencies as being something that is perhaps very dangerous. For example, the federal government has scheduled it as Schedule 1, meaning there is no potential medical benefit. And there have been some agencies that have identified marijuana as being perhaps the panacea, the cure-all, something that can provide holistic benefit for many different medical conditions. I think it's important to consider that the truth may be somewhere in the middle. So just because you're using marijuana doesn't mean that it's causing problems, but certainly it can contribute to your burden of anxiety symptoms.
And just because something relieves anxiety in the moment does not mean that it's relieving the anxiety disorder overall. Oftentimes, something that might relieve anxiety in the moment, alcohol for instance, can actually perpetuate and exacerbate the anxiety disorder. Dr. Baumgart, if I'm taking an SSRI, can I still drink alcohol on it?
Yes. So generally, the use of SSRIs with alcohol is safe. What I will say is if you're concurrently drinking, especially if it's problematic drinking, especially if you're binging excessively and having withdrawal symptoms, including anxious distress, it may limit or it may prevent the full benefit that you're getting from an SSRI antidepressant. But generally, the use of alcohol with antidepressants is safe. The exception of the medications that are generally not safe with alcohol, again, is benzodiazepines. Typically, the remainder of the medications that we've described are not contraindicated with the use of reasonable doses of alcohol.
Dr. Baumgart, if you had to give me just one piece of advice about controlling my anxiety, what would it be?
I would be at a loss to give you maybe one thing that might work well for you, but I would encourage you to seek the help of a mental health professional. I would encourage you to do your own research. I would encourage you to consider different treatment modalities. I would encourage you to consider that maybe all the aspects we talked about today may be helpful. And sometimes it can be a bit of a trial and error process because different things work for different people.
Yeah, let me throw in some advice. If I had to give one piece of advice, what I was saying earlier, do your best to evaluate, is my fear or worry grounded in reality, or is it clinical? Meaning, am I totally overestimating the chances of a horrible outcome? If your worry or fear is clinical by this definition, where it's totally disproportionate to reality, do your best to not allow that to dictate and drive your behavior. Break the chain of clinical fear and worry and behavior And that will help extinguish the fear. Do not entertain it. Do not give it power. When you give it power, you legitimize it, you validate it, and you perpetuate it. And yes, whatever shame or embarrassment or whatever is preventing you from seeking care, for the love of God, we do this for a living, right?
Correct.
Come in. This amount of suffering when you're clinically anxious is insane. Please let us help you. Please. Now, we're going to leave Dr. Baumgart's information down below. Thank you very much for joining us. Any parting words before we say goodbye, Dr. Baumgart?
Thank you. It's been a pleasure, and we'll look forward to picking it up next time.
All right. Thank you very much. Welcome to Real Mental Health with Dr. Mike Mah. We will see you on the next episode. Thank you.